Mikrofon çalıştı. Yansılar da geldi. Evet, start. Herkese günaydın.
Good morning. I believe that there will be more participants. But anyway, let's start our presentation because we have limited time and other colleagues are going to make the presentations. I'm going to talk about the relationship between neuroprotection and GABA. This is my outline for the presentation. I'm going to talk about I'm going to start with neuroprotection, and then I'm going to talk about neuroprotective agents, and then I'm going to talk about their relationships with GABA, and I'll present you some evidences. When preparing this panel, the organizers selected a title which says, "Is neuroprotection reality or a myth?" And at the end of this presentation, are we going to find the answers to the questions in our minds, or are we going to have more questions? We are going to see. Well, neuroprotection. Neuroprotection is returning a portion of the neuronal damage, or using some agents that further avoids the application of injury. We are calling this as neuroprotection. There are some reasons causing the neuronal injury. Among them, we can count hypoxia, ischemia, bleeding, some metabolic disorders, degenerative diseases, which are very interesting for us, infection, endogenous or exogenous toxins. So, the effects of damage are caused by the excitatory amino acids, free oxygen radicals, nitric oxide, calcium, pro-inflammatory mediators, and also the cytokines and bioactive lipids. When we talk about excitotoxicity, mostly we are talking about the glutamate and related compounds. Glutamate is the main excitatory transmitter, and it's responsible for 75% of the cerebral excitatory transmission. When there is a damage, there is an injury, we have the depolarization, and just after that we have the glutamate release, and together with that we have the NMDA and AMPA receptor activation, which is stimulated by glutamate. And in more than 90% of the injuries, this is the mechanism that we have. After that, we have the calcium overload inside the cell, and in addition to that, we have the mitochondrial dysfunction, some oxygen radicals that are coming into play, and through the mitochondria, some proteins are formed, and apoptosis and necrosis is seen. When we talk about neurodegeneration or neuronal injury, this is the mechanism that we are talking about. Hypoxic ischemic brain injury. This is the topic that is studied and researched the most. In the basis of this, we are talking about asphyxia, and we know that this is an activation in order to protect the body. We have the increase in the blood pressure, and the heart is increasing the volume in the cerebral hyperperfusion. However, if we continue with asphyxia, then there will be a reduction in the cerebral blood flow, and then the events are triggering one another. On the one hand, we have the lactic acidosis, which causes the tissue damage, and then the ATP, very high energy phosphate compounds, lose their functions, and particularly in the mitochondria, the functions are distorted. Therefore, the domino effect is seen. These events can range from minutes to hours and days. First, we have the triggering phase, and then after that, we have the glutamate receptors like NMDA receptors, adenosine receptors. They are also very involved in this process. Then we are talking about the signaling phase, and then there is a calcium influx. and the calcium imbalance is taking place. And most of the time, until the calcium imbalance, neurodegeneration can be returned back. However, after that, we are talking about the genomic phase, and most BCL2, CREB, and COX2. So this is actually causing a real imbalance in the body, and then up to apoptosis, this process continues. And according to the information that we have right now, at this stage, the situation, the injury is irreversible. Whenever there is energy deficiency, there are two causes that are leading to neuronal injury. Firstly, we have the glutamate that is impaired, and its reabsorption is distorted because in the synaptic gap, the sodium-potassium pump is not functioning. Secondly, again, on the basis of the glutamate, the NMDA and AMPA receptors are stimulated, and the cells have more permeability for sodium and calcium. In the end, there is an increased concentration of intracellular sodium and calcium, and mitochondrial damage, and some other domino effects are seen. So, at this stage, if we can stop this cascade, then the permanent brain injury can be prevented. But unfortunately, this reverse action is up to this point. Once we pass this point, it is not possible to reverse the injury as of today. In neuronal injury, intracellular calcium is increased, and this is the critical stage, as we have said before. The reason for that is some proteases, some lipase and endonucleases, which can destruct the cell. These are the enzymes that can have the normal functioning of the cell, and when there is a high increase in calcium, they are over-functioning, and it is destroying the cell itself. So this is the problem that is caused by the calcium increase. As we said before, up to calcium overload, this can be prevented. So this area is shown in green. So if we can intervene at this phase, as early as possible until the calcium increase, then we can have more effect of protection. However, if the mitochondrial damage is already started and some oxygen radicals and some proteins cause death, then the neuronal injury, apoptosis or necrosis is seen. And when we say apoptosis, it is a protective system for the organism when compared to necrosis. Because if we are talking about necrosis, then we are not talking about apoptosis, because by means of certain genetic programming, the environmental issues, the neighboring tissues are not affected that much. So this is also a protective mechanism, in a sense. Excessive activation of the glutamate receptors cause the damage and destruction of the cells, according to the researchers. However, if we prevent the excessive activation of glutamate, can we ensure neuroprotective effect? About this, the NMDA receptor antagonist and AMPA receptor sensitivity is changed by certain agents, and one of these agents is memantine. You know that it is a non-competitive NMDA receptor antagonist that is seen in Alzheimer's disease. It is causing a neuroprotective activity, and it is also showing some neuroprotective characteristics, although debatable. So, we are talking about the neurodegeneration, the causes. After having a look at that, we can talk about some neuroprotective agents. So many agents are tried. And we have colleagues coming from Russia. I'm sure that they are going to make the presentations about those agents. Very generally, I'm going to talk about these agents that are having a neuroprotective effect.
Bunlardan en çok glutamat reseptörlerinin bazı alt tipleri üzerine selektif blokaj
Well, these glutamate receptors are causing some selective effect, and some endogenous receptors are changing the sensitivity of glutamate. We have the quinolinic acid. This is causing, this is ensuring the protection of the neurons. And neuroprotective effects can be seen as a result of ensuring the balance in this. And also, we have the minocycline. Within 24 hours after transit middle cerebral artery occlusion, in the event of the implementation, will be a reduction in the volume of cerebral injury. This is shown in studies. And also, there is another molecule which is very popular. It is the BDNF. Its protective effects are seen, and its effect is that it's stimulating the MAP kinase pathway, and it is also stimulating the TRKB receptors. Therefore, it is reducing the apoptosis. So, in order to have the neuroprotective effect, we need to block some mechanisms like excitatory amino acid receptors and glutamate receptors, particularly NMDA receptors, are seen very frequently. And therefore, it is actually causing great damage to the body, and ketamine and other agents are used in some of the animal models to cause the schizophrenia.
doğru giden bir yan etki. Sodyum kanal blokörleri denenmiş, davranış üzerine etkilerinin az olması sebebiyle tercih edilmiş bunlar. Voltaj
And also the voltage gauge sodium channels are blocked in order to prevent the sodium inflow. And therefore, the excessive amount of calcium and the damage caused by this is prevented to a certain extent. Well, the antioxidant capacity is very low in the brain. And can we use melatonin as a result of this? This is researched in some of the studies. Melatonin is catching the free oxygen radicals, according to some researchers, and some nicotine receptors are showing the neuroprotective effect in the central nervous system, and also in some of the cognitive diseases. This is shown as a protective effect. In Alzheimer's disease, some receptors are increasing the cognitive performance, and norkitokin is a metabolite of nicotine, is bound to beta amyloid, and peptide aggregation is ensured. And it is also, there are some evidences showing that it is reducing the formation of plaques. Also in Parkinson's disease, the nicotine presynaptic dopamine release is stimulated, and postsynaptic dopamine receptor activation is caused as a result. In Parkinson's disease, it is causing a partial cure or recovery, let's say. Similarly, as a neuroprotective agent, vitamin E is investigated. And there are some evidences showing that after the vitamin E implementation, Alzheimer's disease progression is slowed down. And also there are some new molecules like sputrigine and riluzole.
In vitro çalışmalarda
In vitro studies, it is shown that they are causing also, they are ensuring neuroprotective effect. Lamotrigine is also cerebroprotective after focal ischemia in different parts of the brain, according to some researchers. And its effect is on the reduction of the release of glutamate, and the calcium and sodium channels are modulated. This is the most critical point. So this is an effect of lamotrigine. Again, one of the neuroprotective agents is topiramate. You know that it is used in epilepsy and sometimes in schizophrenia. And of course, not in the general treatment of schizophrenia. It is ensuring the positive modulation of GABA receptors, particularly GABA-A receptors. And also, it is ensuring the inhibition of AMPA receptors and sodium channels blockage. And those cells are protected. Yes, there are 100 million of neurons, but much more than that. We have the astrocytes, oligodendrocytes, and they are also causing the survival of the neurons. So this is having an effect on the survival of those cells. And this is also causing the reduction of the apoptosis of the cells. And microglial activation is suppressed. Astrogliosis is ensured. Therefore, the protective cells around the neurons are increased in number, and seizure activity is decreased. Talampanel is also an anti-epileptic. It is an AMPA receptor antagonist. It is used in the middle cerebral artery occlusion, and it is also decreasing the infarction volume, and it is neuroprotective in the patients with stroke. As a result, in order to protect the neuron, so many agents are tried, and I just mentioned a couple of them. There are tens of them that are being tried right now. And in a 10,000-page encyclopedia, in every 60 or 70 pages of them, there are neuroprotective agents. So we can say that this is the most important topic that is researched in the neuroscience. Have you reached the result? No. Because there is no agent that is ensuring the protection from neuronal damage to 100%. However, there are promising results. In the last part of my presentation, I'm going to talk about the relationship between GABA and neuroprotection. I'm going to summarize three publications. The pathophysiology of cerebral damage is multifactorial. We talked about the glutamate, but there are so many other factors involved in this process. We know that if there is glutamate in some place, there should be GABA next to it. If the glutamate is the stimulating system that is accelerating the system, then GABA is...
Şimdi 2013 yılında yayınlanmış bir çalışma.
Break of the system. So this is a study carried out recently, and the effect is shown through the allopregnanolone, and some sub-pathways are investigated in this study, and this was done on rats model. Progesterone is a neuroactive steroid. It is synthesized from cholesterol, and its effect is shown through algoprelinone. And in the central nervous system, it has a protective effect. Together with the environmental chemicals, it is debatable whether it has a neurotoxicity protective mechanism. In the rat hippocampal slice, in the cell cultures, they checked whether we can have an impact with progesterone on this damaging mechanism. So we can see this mechanism from cholesterol. There are so many steroids and hormones that are released. Progesterone is very important in terms of neuroprotection, and this is the allopregnanolone is the agent that we are focusing on. When we say allopregnanolone, this is an agent that is having effects similar to benzodiazepines. This is the gamma receptors scheme, and it is binding to the GABA receptors, and it is causing sedative, hypnotic, anesthetic, anxiolytic, and anticonvulsion effects. So there are benzodiazepines, and the binding place of GABA, ethanol, and just like the allopregnanolone, there are some anti-epileptics that are binding to this GABA receptor. And also there is the mediation of amygdala in the effect of this agent. Neuroactive steroids are binding to various receptors. However, the most common one is the GABA-A receptors, because their interaction is much more important. Benzodiazepines, barbiturates, neuroactive steroids are much different than GABA-A receptors. Allopregnanolone and 3-A and 5-alpha-THDOC are the most effective endogenous positive allosteric modulators. So these are affecting GABA in a positive way. Allopregnanolone and 5-ATH-DOC. Tributylin is given in order to have the hippocampal damage in rats, as you can see. This is the untreated group. And TBT, tributylin, is given at various doses, and the damage is caused, and cell death is caused up to 100%. Allopregnanolone is used in order to see whether it is preventing this damage. Before looking at the details of this study, I'm going to talk about TBT just a little bit. Tributylin is used to cause the neuronal damage, and it is an organotin compound. Organotins are used in wood industry, textile, and electronics, and mostly it is used as a protective substance. And particularly TBT is used in the fishing sector, in the boats and ships. And when we check the blood levels, who are eating the sea products, aqua products, and they have the TBT compounds from 50 nanomolar to 400 nanomolar level. Of course, we are eating all the fish, and they are all very nicely. You can see the sea, wood, and seafood. But in the end, they are all related with TBT, and that is causing damage in the brain. So, tributylin is used in order to cause the damage. You can see the first column causing the damage, and neuronal cell, the neuronal death. So, and you can see the doses of tributylin. Together with tributylin, when we administer progesterone, then this cell, death and this damage is reduced by half. That is, progesterone is ensuring a neuroprotective effect. So, is it related to GABA and GABA-A receptors? And finasteride is used as a GABA receptor antagonist. When they administer finasteride, then the allopregnanolone amount in the tissue is reduced by 20 folds. From 1200, it is dropped down to 50. And when we look at the cell death, normally the cell death was caused by TBT. But then, together with progesterone, the cell death was reversed up to 50%. However, together with the TBT, progesterone, if we use finasteride, then all the gain is just lost. So, they say the GABA-A receptors are the mediators to this damage, and they say that this is the evidence to that. The second publication that I'm going to talk about, it was published in 2013, and oxidative stress is used in the Parkinson disease rats. And in rats, the 6-octa is given in order to cause oxidative stress. Therefore, Parkinson model is established. And 5-HT and GABA is used in order to see whether it is reversing the oxidative stress effect. and the NADPH oxidase levels are measured. I'm going to summarize this in one single slide. This is the control group, and this is the damage caused by 6-OFTA. And the catalase amount is reduced by 5 folds. Both serotonin and GABA is reversing this damage, and if they are given in combination, then they are even close to the control group. So the oxidative damage is completely reversed. This is one of the effects of GABA. Therefore, GABA is just like the brake mechanism of our brain. So if we have excessive amount of glutamate, then it has to be in the mechanism. The body is doing it itself, just like in the automatic state-of-the-art technology cars. So when we have the glutamate release, then we have the GABA release in the synaptic cleft. And this activity is a little bit inhibited by GABA. And also, mitochondrial-related agents are used in order to ensure the survival of the neurons, but they are not always enough. That is why we are still researching these neuroprotective agents. So, normally, when the car is going, we use the accelerator. However, if there is something on our way, we have to stop the car. I'm going to confuse you a little bit with this last research. Okay, we said GABA is the brake and glutamate is the accelerator. We need to put the brake sometimes. So, but this research is telling something else. This is a publication published in 2003. It is researching the neuroprotective effects of nicotine. You have just 2 minutes. So, which neuroprotective mechanisms are involved in this process is analyzed in this study. The nicotinic acetylcholine receptors are regulating the neuroprotection, and it is preventing the excitotoxic and apoptotic cell death. In this study, the alpha-7 ACHRs are controlled by this mechanism according to the evidences gathered in this study. I'm going to summarize the parts that are related to our topic in this study. NMDA is given. It is a receptor of the glutamate, and the damage is caused. And the neuron spikes are measured in order to understand the level of the damage. And then the BMI is given. BMI is a GABA receptor antagonist. Normally, we were talking about the GABA as a brake, and when we have that, we were expecting the recovery, neuroprotection. However, here, when we say GABA, and when we inhibit GABA by means of BMI, then they observed some neuroprotection. However, in this study, they did a very nice design. They spent great efforts in order to do this design. The BMI concentrations are at various levels. I mean, they inhibited GABA in 0.05 and 0.1 doses. So if you inhibit GABA and the brake is not causing the expected neuroprotection, and if you block GABA to a great extent, then the neuronal recovery is reduced. This is my last slide. So again, this is the car, that is our brain, and when we have a a road with ice, an icy road, we need to put a brake. But when we are doing this, we have to be very careful and slow when using the brakes, just like on an icy road. And if we just put the brake so hard, then we may cause a traffic accident. Thank you very much for your attention.